Okay. A fibroadenoma. Who'd go for a fibroadenoma? 1, 2, 3. I don't know all the rest would vote for what, but anyhow, let's see. Carcinoma. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9 maybe. An oil cyst. 1. Okay, 2. An oil cyst. Okay. A degenerated fibroadenoma. Why? Why a degenerated fibroadenoma? For God's sake. Let's go back to the images. Usually, fibroadenoma appear what on T1 and T2? High or low signal? Low to isosignal in T1 and probably slightly high signal in the inversion recovery. Unless what? What? Yes, unless it is calcified. We have seen here, it's very dark signal. The signal is not just hypo intense, no, it's dark signal. Is there a proof to know that? Yes, very simple. And that's a calcified fibroadenoma. Can you see it? Where is the arrow? Calcified fibroadenoma. Okay, case number 7. 40 years old with positive family history, multiple left breast cysts, fine needle aspiration cytology, turned out to be fibrocystic disease. This is a very common presentation. You will meet with these cases almost every day during your routine practice. Dense breast parenchyma, nodular pattern, ultrasound, multiple cysts. But anyhow, let's go for our challenging cases. This is the MRI images. Axial T2 inversion recovery images, axial T1 and sagittal T2. What do we see? We see cysts. Yes, that's true. Multiple cysts in both breasts. So let's go for the next enhancement. Okay. I will not comment on the contrast enhancement except just give me a couple of minutes to see how would you interpret these images first. Do we have enhancement? Yes, we have enhancement. But what kind and what type of enhancement do we have? It's really, we can say it is a marginal, but the wall is very thick, and we have some other. But anyhow, I will comment later. So, the question is it benign or malignant? Post-fine needle aspiration cytology sequela, infected cysts, or carcinoma? Okay. Who would go for just the routine post-fine needle aspiration cytology? Who would vote for number 1? No one. Okay. I agree. Number 2, infected cysts. Who vote for infected cysts? 1, 2, 3, 4, 5. Only 5. Why not? Why not infected cysts? We'll discuss that. Who vote for carcinoma? 1, 2, 3, 4, 5, 6, 7, 8. Most of the attendees are silent, but anyhow, okay, I know that they are deep inside, they have the correct answers. Okay, So why we say carcinoma and not infected cysts? Or why we say infected cysts and not carcinoma? Why? Look at the science. Let's go back. As I said, and I'm always telling you, a simple cyst does not enhance. Or it might has a very, very thin, uniform enhancement of its wall. Very thin, uniform enhancement. But what do we have here? We have a very thick enhancement of the wall of the cyst. Is that all? No. Look at this. What are these? What are these doing here? And what is this doing here? This is a mass. And what is this linear enhancement that's going up to the nipple? Fibrocystic disease should not have this pattern of enhancement. Whenever you find this peculiar linear enhancement that is going from a nodular mass enhancing lesion directly to the nipple, and we have a cluster of enhancing nodules, yes, there are cysts, but among the cysts you may find cancer hidden there. So not just putting your probe on the breast and find many cysts and you're happy, you're taking very nice pictures and that's it, okay, multiple cysts. No, be careful. Cancer can arise among these cysts. Any lady who has got multiple cysts, she's not immune for cancer. And this is quite often we just neglect to see multiple cysts and that's it, fibrocystic disease. Please take care. Take utmost care. This is very, very troublesome, and sometimes you find it difficult and time consuming to perform the study. But anyhow, this proved to be a carcinoma. Sure it is. An invasive duct carcinoma. Number 8, 60-year-old woman with left breast mass at 6 o'clock. Now the question I'm going to raise here is how many lesions or how many anatomical areas are there in the following images. I'd like you all to concentrate on the upcoming video. I'm sure you can all detect this joint and big lesions, but many of you would fail to detect the smaller lesions. I know that watching a video is not like in your practice, but in your practice you'll do the same. But anyhow, this was the post-contrast subtraction images. Now I'll show you the inversion recovery images. How many lesions did you detect? Okay, this might be difficult for the brain to follow the video, but anyhow, we'll go bit by bit. How many anatomical areas that showed abnormality? 1, 2, 3, 4, 5. And by anatomical areas, we mean a breast is an anatomical area. Okay? So, 1, 2, 3, 4, 5. Just yell. 1, 2, 3, 4. Someone is saying 5? 5? 2? Okay. So most of you are between 3, 4, 5. Okay, it's just counting. I mean, there is no problem about that. So, let's go for the images. The MIP, the subtracted images, and the inversion recovery images. So, let's count together. This is 1. We said the breast is one anatomy. 2, axillary lymph nodes. Sorry? Contralateral axilla. Okay. What? Yes. Very clear. We have 1. So 3 now. Are we satisfied with 3? More? What's this? The arrow is pointing to something. Okay. Maybe this image doesn't show you this arrow in particular, but I will show it in the video again. What's these? These are mediastinal lymph nodes, anterior mediastinal lymph nodes, or peri-aortic lymph nodes as well. So 1, 2, 3, 4, and 5 within the manubrium. So this lady has got a multi-centric tumor with axillary nodes, with bony metastasis, with mediastinal lymph nodes. Yes, there are on the right side, there are some small axillary nodes, which we often find in our routine practice. Now, this brings us to the debate that I just listened to in the role of imaging in assessing the axillary lymph nodes. I would like really to mention something that might be disappointing to you all. Don't depend on the imaging in assessing the axillary lymph nodes in a sense that our specificity is low. The axillary nodes, you mentioned its size, yes, the number, the shape, the fatty hyla. This is all description. The enhancement, all lymph nodes enhance. This is quite natural. And the diffusion and spectroscopy, I heard lots of things, but in the literature, still the debate is there. No real agreement on the value and the usefulness of all the procedures done. There are many false positives and many false negatives regarding the spectroscopy as well as the diffusion for the axillary lymph nodes. I know that some of the research going with and others are anti. So stick to the basics. Whenever you have a technique that you may use it. But you should be aware of all the pitfalls that might be there. Nothing is perfect. If we have I heard from Ran that we have a morphological, and that's the basic thing, the morphology. The kinetics, okay, it might be good, and we're still using it, and use it, but you should also be aware of the pitfalls. Like, for instance, yesterday we had a debate about the kinetics in the lobular carcinoma. Most lobular carcinoma would behave as benign lesion, or at 3. Most of them would had the benign lesion, a type 1 curve, rising, continuous rising. So, if it is type 3 and the morphology is suspicious for malignancy, well and good, we're happy. If not, stick to the morphology. Again, the same applies for the spectroscopy and for the diffusion. If they are matching, well and good. You add more scores to your suspicion. If not, okay. I mean, the spectroscopy and the diffusion still, there are many researches are done on them and still some argument. But I don't like the idea that we defend a certain or a peculiar type of investigations and forget about the basics. The basics is the basics till this moment. Okay, 9, then I think this would be the last. A preoperative under chemotherapy. Patient with advanced locoregional breast cancer, they take neoadjuvant chemotherapy and come to you. Please check out if the tumor has responded or not. And this is the value of the neoadjuvant chemotherapy. So, this is our patient, 47 years old. She had a left breast lump that turned out to be malignant and attached to the skin at the left upper inner quadrant. The pathology, grade 2, invasive ductal carcinoma, ER/PR negative, HER2/neu 1+. This was in October 2006. Now she did a mammogram, October 2006, and the lesion is quite seen here, the big one, as we can see here, and here again. She did a mammography in December after 2 months of starting the chemotherapy, and the mammogram showed us 1 centimeter mass, a residual 1 centimeter mass with the mammography and with the ultrasound. So the surgeon is happy. Now there is understaging of the tumor. The oncologist is happy of what he did. But is that all? Should we all be satisfied that the lesion just from 3 centimeter became 1 centimeter? Okay. Now further further chemotherapy. In April 2007, now we started at October. Now April is 6 months later on. The mass really vanished on the mammogram. We don't see it anymore. Good. The oncologist did a wonderful job. So oncologists asked for the MRI. And that's the pictures of the MRI, an axial T1 and an axial T2 inversion recovery. What do we see here? We see some abnormality at the site of the original tumor. One would say, okay, this is residual tumor. Others would say, no, this is a scar from the burned tumor. One would say, okay, come on, guys, let's inject contrast and see. This is essential. No MRI, please. No MRI without intravenous contrast. No one would come to you, please, I want to do an MRI, but I don't want to take any contrast. Go home. Don't do it. Sometimes the only exception is that when we need really to assess, for example, prothesis rupture. I don't find any other indication for that. And even though we also should inject contrast, maybe she's got a cancer and we are just focusing on finding capsular rupture also. Anyhow, this is the images. Contrast enhancement. No contrast enhancement. Oh, oncologists did a wonderful job. But the question here what's this? And why it's not showing with contrast? So the question is really to you. Are we having a residual tumor or not? That's the question that you should write down in your report. A, yes, there is residual. No, there is no residual. So, who vote for there is a residual tumor? 1, no, 2, 3, 4, 5 for residual tumor. Now, the others, I would assume there is no residual tumor. Who vote for no tumor, no residual tumor? 1, 2, 3, 4, 5, 6. Okay. Before we say a word about is this a residual or not, we should really know how to differentiate. So, I'll discuss with you what you may have read in one of the books about the camouflage sign and a dissolving tumor sign. Camouflage, meaning it's you're being, or the tumor has deceived us. It's hidden, but camouflage, just deceiving us. So what's the difference? Camouflage, T1 and T2 show the tumor bed. There is the tumor bed. While a dissolving tumor sign, meaning no abnormality on T1 and T2. So, a camouflage, there is a tumor that only shows on T1 and T2, while the vanishing tumor does not show any abnormality on T1 and T2. So, if we have abnormality on T1 and T2 with no enhancement, in both conditions we don't have any enhancement. But if we have abnormality on T1 and T2, we have still viable tumor still there, hidden, resting. And if we don't have enhancement, we don't have any abnormality in T1 and T2, so really the tumor has been melted down, vanished, gone. So this is the basic difference. So please always remember these facts. So the answer is yes, there is residual disease. And by that, I thank you very much. And I hope
this Okay, thank you very much, Dr. Ashraf, for these very interesting cases. And is there any question on the cases? Okay, with this, we thank you very much, Dr. Ashraf, for your presentation and close this session, probably the conference.